So it's my great pleasure to introduce Dr. Baris Turkbey. We have a video link with him, so we'll see if we can get this going.
Can you hear me? Okay.
Yes, we can.
So, hello everyone, I'm Baris Turkbey from NIH. I wish I could be there today, but due to some reasons I couldn't, but I will try my best to present our work on prostate MR imaging. And it's going to be, the title is From Diagnosis to Therapy. So prostate cancer is the most common cancer type among American men, and 1 in every 6 men is diagnosed with prostate cancer, but only 1 in 36 will die from that disease. This simple statistics brings us to basic questions. Are we over-treating the indolent prostate cancer lesions? In other words, can more focal therapies be designed for low-risk patients? And are we underdiagnosing lethal prostate cancers? So our clinicians are trying to answer this question, but as imagers, as radiologists, we have important duties to help them in answering these questions. And these are the basic modalities that we use in imaging of localized prostate cancer. The first is the transrectal ultrasound, which is mainly used for guiding the biopsies nowadays. And we have CT, which is used for depicting the distant disease, but not the localized disease too much. We have MRI, which is working fine in the setting of the localized prostate cancer. And we have PET-CT with no figures, and MRI are quite often topics. And today's topic will be mainly MRI of localized prostate cancer. I would like to introduce you our program a little bit. We have our own three-tester machine in NCI. We are an intramural program, and we are using endorectal coil, and we are using also anterior half of the 32-channel cardiac coil for doing our prostate scans. Our volume is about 20 patients a week. And these are some more details about how we do these scans. The endorectal coil has a balloon inside, and we put fluorinaire, inflate this balloon, which provides us field homogeneity for spectroscopy and for diffusion-weighted MRI. We cover the balloon with lidocaine, which makes the scan easier for the patient because it's a semi-invasive type of MRI. And this is the basic sequence of our MRI protocol. Mainly we have anatomical and functional sequences. The anatomical ones are T2-weighted MRIs in 3 planes, and then we have diffusion-weighted MRI, MR spectroscopy, and finally dynamic contrast enhanced MRI. I'll briefly summarize our protocols. We obtained the T2-weighted MRIs in 3 planes. It is a very high-res scan. The resolution, in-plane resolution is about 0.3 millimeter by 0.3 millimeter, and these are the backbone of this imaging modality. And then we obtain diffusion-weighted MRI. We normally get diffusion-weighted MRI by using 5 evenly spaced U-values between 0 and 750, and then we calculate the ADC maps, and mainly we use the ADC maps for getting the diagnosis with MRI. The ADC maps are quite interesting type of sequence because it assists us in diagnosis, but also it helps us to predict the Gleason grade and the tumor aggressiveness of prostate cancer lesions, and we have shown this negative correlation between the ADC values and the Gleason score and the Dunning clinical risk score in one of our recent publications, as you can see here. And then the next will be MR spectroscopy. We obtained a 3D multifocal spectroscopy. As you can see here, that's the planning of the spectroscopy. It takes about 30 minutes to obtain. I know many centers in the world do not apply this, but we do it for research purposes. And we process the data in an offline image processing tool, and here you can see that these are the curves we get for spectroscopy. And then finally, DC MRI. We obtain the DC MRI by using fast gradient echo sequences. We inject the contrast. We start imaging before injection. We imaged before, during, and after injection. Our temporal resolution is about 5.6 seconds. We get 54 phases. And we use the basic dose, which is 3 ml per, the dosing is 3 ml per second. The DC MRI data, we evaluate it in 2 ways. We visually look at the enhancement and the enhancement of the lesions. As you can see in the sample, there is a tumor, there's a lesion in the left mid-peripheral zone. It is enhancing, it's the raw DC MR image, but we also use a commercially available software for get more quantification of this DC MRI. We basically use iCAD software, and we're going to get more details about this. And finally, after everything, we obtain a torso scan, which we look at the bones and lymph nodes and solid organs, because in some patients we may see this in a moment, and our surgeons want this for a full staging with MRI. Well, with the setup, with the protocol that you have seen, we published our first paper in 2010 in radiology, and we were able to show that using a multiparametric approach improves the predictive power of MRI for tumor detection. But during that project, we encountered into a big problem. In most of the patients, what we see on MRI, as you can see here in the right apical peripheral zone, was not matching well with the pathology. But we were quite confident that this lesion is corresponding to that in the pathology. And then we used a neighboring approach to overcome this problem. But this obviously diluted our results. So we realized that the prostatectomy specimens were not handled and processed in this properly. So what we did was we come up with an idea of a mold, which is based on the MR images, the in vivo MR images. So by using these fancy printers, we printed out these molds, these customized molds, which helped us to get the same geometry of the pathology specimen with the MR image. Well, the first set of 100 patients, it was costing about $135 per each patient, but we bought a very, very cheap computer, a printer, and then we made it as a routine for all of our patients. Now, every patient who's getting prostatectomy in NCI is getting an MRI, and then getting an MRI-based mold, which costs less than $10. So you can see, while using this mold, you can slice the specimen with the same geometry of the MRI, and the result is really good. And by using this, we published our updated results with 45 patients, and here you can see the real utility of multiparametric MRI for predicting presence of cancer in a localized setting. And we come up with the result that, like, lesions greater than 5 millimeter and lesions greater than, with a Gleason score of 3+3, we are quite confident in localizing these diseases. But the main problem of the current setting of the MRI is the endorectal coil. Endorectal coil is about $170, and it is not reimbursed with any system in the world. So it brings a cost, and it is invasive. So with the current setup, it is not really the future. It may be used for staging, but not for screening. And in the meantime, I'm sure all of you guys are aware of this report of the U.S. Preventive Task Force about the PSA. They gave a grade D for PSA for helping the patient with prostate cancer. So PSA is not helping at all. So it is not a good screening method. So it needs a replacement. The MRI, a simpler MRI without an endorectal coil, can be a possible candidate to replace PSA. So we did this research in 84 patients, and 20 of them had undergone prostatectomy. And the top row, you can see an image without the coil, and the bottom row is the image without the coil of the same patient in the same day. We just did T2-weighted MRI and diffusion-weighted MRI. And here you can see the resolution is not so great, but you can see the large lesion in the right apical anterior gland, and the histopathology is quite matching well with that lesion. So we were able to accrue 84 patients, 20 of them had prostatectomy, and here you can see endorectal coil MRI has a better sensitivity, has better positive predictive value, and it detects smaller lesions. But when you analyze the dominant tumors, which are the largest with worst Gleason scores, the endorectal coil MRI can catch 17 of them in 20 patients, and the non-endorectal coil approach catched 15 of these 20. So the difference is just 2. And so this is a good sign. So an MRI without endorectal coil can be implemented into the system before the biopsies, can replace the PSA. Of course, if a patient has a diagnosis, he's going to have definite treatment, then you may need the high-quality MRI. But the results are really promising for without coil MRI, with just 2 sequences in 20 minutes. At this stage, I really want to briefly talk about how we read these MRIs. I'm sure every center has their own method. So we have this sheet for every patient. We have T2, seminal vesicles, we have extracapsular extension, the diffusion spectra DCE finding of the single lesion. And we have a grading system, which has 2-3 categories, depending on how many sequences a lesion is positive. And I mean, we have low, moderate, high suspicion. High is corresponding to that lesion is positive in all 4 modalities on the multiparametric MRI. And this result was supported by a recent publication by one of our colleagues in Journal of Urology. So the low, moderate, high was showing good correlation with D'Amico. And if you can see here, the high suspicion with MRI is resulting in high yield in targeted biopsies. So this is our approach in how we read these patients. In the meantime, we are aware of PIRATS, which came from ESUR. We were a part of that PIRATS system, and it is being evaluated by American College of Radiology. It's a really important thing. It will help us to talk the same language. So we are represented as NCI in DCMRI and T2 weighted committees of the PIRATS. So this is still under work. I mean, it needs some work to be implemented to the U.S. system, but it's something promising. So for diagnosis of prostate cancer, imaging is an important component, but findings need to be validated by biopsies. And now in the next few slides, I'm going to show you how we do these biopsies, these image-guided biopsies in NCI. We build up a system in NCI. We obtain the MRIs. We process the MRIs. We segment this prostate gland. We mark the lesions on these MR images. We export them into a platform which fuses the MR images, pre-obtained MR images, to the real-time transrectal ultrasound. The system basically utilizes the medical GPS. And here are the inventors of this system. And we are working with Philips to build up this system. And this is a sample video. I mean, the benefit of this system is that many lesions in the prostate are not visible on ultrasound, but visible on MRI. Doing these biopsies in the gantry is quite tough. So this system brings MRI into the office space. And here is a small lesion, and this is the needle guide. And you can also move the MRI, the pre-obtained MRI, in the same time, and then just a small lesion is sampled accurately by this system. And here you can see the needle. So this is our biopsy approach. The medical GPS system, which fuses MRI to ultrasound in a rigid registration basis, rigid volumetric registration basis. So this system has been validated, and this is the first publication that we get from this system written by Dr. Pinto, and this is the result of the first 100 patients. And here you can see this is the low, moderate, and high suspicion level for each lesion on MRI. And we have seen a significant increase in the yield of the target biopsies when you compare with the random biopsies. The fusion platform developed by NCI and Philips was tested in over 700 patients, which is corresponding to 10,000 needle cores, and we use it routinely, like 10 times a week. So in this phase of my talk, I'm going to show some examples, some case examples. But before that, I would like to make you more familiar with the MR anatomy of the prostate. So this is an axial T2 weighted MRI with a very high resolution. The PZ appears as a bright compartment. The central gland is a more heterogeneous compartment. You have this pseudocapsule in between those two. This is the urethra. And the dark rim around the PZ is the capsule of the prostate. The neurovascular bundles are on the posterolateral parts of each prostate bilaterally, and this is the anterior fibrous stroma. The seminal vesicles are sitting on the top of the prostate, and they appear bright due to their watery component. This is a quite common pattern, which we call as BPH, benign prostatic hyperplasia. And this is how typically a tumor lesion appears in the peripheral zone. It is a dark region. This patient has a capsular bulge, which we will talk about a little bit in more cases further. And this is a sample of seminal vesicle invasion. It appears dark again within these bright filled tubules. So the first patient. This is a 66-year-old man with a PSA of 6 with a Gleason score 3+4 at a random biopsy. And the T2-weighted MRI shows a large lesion in the left mid-peripheral zone with a capsular bulge. That lesion is positive on ADC map. This is how the tumors appear with restricted diffusion on ADC map. And this is the MR spectroscopy result of the same lesion. In spectroscopy, healthy spectroscopy, you have a low colon citrate ratio, but in case of tumors, the ratio flips. So this is positive. And this lesion shows early enhancement within the raw DC MRI compared to the peripheral side. And the quantitative map also shows the increased fast uptake within that particular lesion. That patient underwent fusion-guided biopsy, which resulted Gleason 4+5 disease with a high volume. Another patient, 63-year-old man with a PSA of 12.8 with 4 prior negative trans-guided biopsies. I'm going to talk about this in a minute, but this is a quite common scenario that we encounter in NCI. That patient has a suspicious area in the anterior central gland at the apical mid gland level. That particular lesion shows positive features on ADC map. The very healthy peripheral zone, which was sampled, I think, 4 times priorly. That lesion shows elevated colon levels, and the DC MRI shows positive features. That particular lesion was sampled by fusion-guided biopsy, and it yielded Gleason 4+4 disease in high volume in both of these cores. So this is quite common scenario that we encounter in NCI. Another patient, 64-year-old man with a serum PSA of 19.5 with no prior biopsies. This is quite becoming common in NCI as well. There's a very large lesion in the right to midline posterior peripheral zone, which possibly affects the central gland. That lesion shows positive findings on ADC map, and it is spectropositive, highly. This is the colon peak, this is the citrate peak. It is almost flipped. And the DC MRI shows high vascularity within that particular lesion, and this is confirmed by the K-trans map of DC MRI. So we did a biopsy, which resulted in Gleason 4+5 and 5+5 with 100% involvement. So that was a sample for a high-risk disease. We use also MRI in the setup of PSA recurrence, and this is an example for that. 8-year-old patient with a serum PSA of 0.5 after a radical prostatectomy for Gleason 4+4 disease. The T2-weighted MRI shows a very subtle bean-shaped lesion at the superior anastomotic level on the left. That is positive on ADC map mildly, and it is showing enhancement and some positive features on the quantitative map. With the fusion platform, we can target such small lesions, and the result was recurrent prostate cancer. So that was a sample for PSA recurrence. Another sample for a post-treatment patient, 45-year-old man with a strong family history. He's a very young guy, PSA of 9.4. He underwent proton beam treatment for Gleason 3+4 disease, but his PSA kept rising. He came to us, and we did an MRI. The T2-weighted MRI showed a barely visible lesion in the midline, in the peripheral zone, at the mid-base level, posterior to the urethra. And there are some suspicious areas in the seminal vesicles on the left side. And the ADC map localizes the lesion clearly. This is a scenario which ADC maps help you more than the T2-weighted MRI to see the extent of the tumor. The DC MRI shows clearly enhancement within that suspicious area, and it is confirmed by the quantitative map. And we did a fusion-guided biopsy for this particular lesion and for the seminal vesicle, suspicious seminal vesicle finding. So we found Gleason 4+5 disease in the primary lesion here, and we also found Gleason 4+5 disease in the seminal vesicle invasion. So this patient directly underwent surgery considering his age. So we helped him in the setup of post-treatment. And this is my final case example. We use MRI in active surveillance quite a lot. And there's a sample for that 82-year-old man who is too old for a surgery or for a treatment. His PSA is 5. He was diagnosed with Gleason 3+3 disease in the left mid-peripheral zone. We did MRI. There is a lesion in the left mid-peripheral zone anteriorly, in the anterior horn, It is showing ADC features, positive ADC features, and it is showing some enhancement. This was his baseline MRI. We preferred not to do anything because he was fitting perfectly together with his images for an active surveillance strategy. And we did a yearly MRI, and the lesion was quite stable. Just compare these T2 maps, so T2 weighted images, these ADC maps, and the DC MRI features. So this is quite becoming common. The active surveillance for MRI is quite happening common in NCI. So this is the flow chart which summarizes the usage of MRI in our clinic. We have mainly 4 applications. The patient comes with a positive biopsy, we do imaging, and the patient chooses a treatment, which we call it, we use MRI for staging with a positive diagnosis. Or the patient comes without the biopsy, we do imaging, and the patient goes to biopsy, and we found something, or we didn't find something, and the patient follows the regular clinical workflow. Or the patient comes with a negative biopsy with elevated PSA. Then MRI is done. If we see something, we just biopsy him. If we found cancer, he gets treatment. If not, he's good to go. Or we image the patient after the treatment, or after the active surveillance decision is made. So these are the 4 possible scenarios that we apply in our clinic, and these are the fractions of these applications. So you see, 1/3 of our cases are just done for staging, for imaging. 1/3 are being imaged due to for negative biopsy but elevated PSA, and 20% of these patients are imaged for active surveillance. If you compare the numbers with our first 2 years, you see there is a significant decrease in number of MRIs we do in staging, and the shift is towards using MRI for guiding biopsies and for following patients for active surveillance. So this is quite an important shift of paradigm for use of MRI in our clinic. Well, while we are imaging patients for cancer, we also see quite a lot of patients with BPH. Actually, BPH, benign prostatic hyperplasia, is the #1 prostate-related disease in men. It can be symptomatic, it can be asymptomatic, but it's a problem for aging men. And while we were working on that, our clinicians needed a reliable way of reporting the zonal volumes of these patients. And for this purpose, we worked with Pinkun Yan from China. He provided us a semi-automated prostate segmentation tool, which can give us the zonal volumes of the prostate. We started using these volumes and these segmentations, which we get from this tool for using our volumetric registration for our biopsies and for printing our molds. So we ended up by having 500 patients, which were manually segmented, both whole gland, central gland, and peripheral zone. So one of our students, Robert Huang, did an interesting research, and with the largest cohort, which imaged by MRI, we were able to see that by aging, the central gland increases gradually. Sorry, the whole prostate volume increases gradually, the central gland increases gradually, and the PZ stays calm. So we just published that. But having that manually segmented 500 patients, then we seek the way to get this automated. Automated segmentation, automated volume detection, automated segmentation for using these meshes for our biopsies, for our molds, and for several other research purposes. So we worked with ICAD, with a company called ICAD, and we helped them. We gave them this 500 patients, we trained them, and they come up with this very interesting automated prostate segmentation tool. There is no human interface. It works. It gives you the segmentation of the 2 zones in 10 to 5 seconds, depending on the power of your computer. And here is a real video of that. I just clicked the button, and the tool started to work. It localizes the prostate, it refines the prostate, and it segments the prostate. And here is the product. And I'm going to zoom it, and here you can see the central gland is contoured by the red, the whole gland is contoured by the green, and it is working quite well. The numeric and the dice coefficient correlations with manual volumes were quite promising, almost close to 90%. And here you can see it gives you the volume. So now in NCI, for every patient who has MRI, we do the same thing. We report these volumes in our clinical reports, and we use these meshes for our biopsies, for our molds, and for our several other image processing researchers. This is quite interesting. One of our main interests is developing decision support systems, the CANs. Each prostate MRI is about 3,700 images. In the regular clinical workflow, I know radiologists will not like to do it. So we need to have decision support systems. So every group in US is working in sort of creating the decision support systems. We work with Vijay Shah and our senior staff scientist, Marcelino Bernardo, to develop our own system. This system includes the quantitative maps of DC MRI, T2-weighted MRI, normalized with FET, and the ADC maps. And it makes a cluster analysis. And we end up with this cancer probability maps. It works only in the peripheral zone right now. We're hoping to implement it into the central gland, but here you can see there is this hot red area which is suspicious on the DSS system, and on the mold processed prostatectomy specimen, there's a high-grade tumor. So this system worked. And here are the results of that system. We published that in Medical Physics recently, and the precision is about 90%. We don't say that we need to replace radiologists, but these decision support systems can definitely aid the radiologist, can enhance this reporting of this high-volume prostate MR scans. And recently, we put 26 images to a government website through which anybody in the world can access. And we put these multiparametric MRIs with the whole histopathologist live. So anybody who is interested in making image processing, in developing CAD systems, in developing segmentation algorithms, or anything else that they want to work on, they can access this website, they can download these images, they can play with these images, publish, and they can come up with a solution. We just want the solution. So the whole point is you guys can have these cases whenever you want. Just click this or just email us. So when you diagnose a patient with prostate cancer by using the MRI and the MR-guided biopsy, I mean, it's not over. You have to make a solution. The patient has cancer, will it go under active surveillance or under active treatment? It is important, especially in the area of the PSA. I mean, currently, we just rely on the nomograms. And these are several nomograms, but the basics are D'Amico, Epstein, Capra, Klotz nomogram. We have lots of them. But they are not very accurate. I mean, an MRI doesn't appear in any of them. We conducted the research in 133 patients. We tested MRI scoring system to stratify active surveillance versus active treatment, and we compared our results with the 3 biggest nomograms in the world. And here is the result. Each column represents a case. The yellows, the top row is the gold standard, and the ground truth. The yellows are the active surveillance candidates, so active treatment candidates. The oranges are the active surveillance candidates. And here you can see MRI made the least amount of mistake in correctly stratifying these patients. We don't say MRI should replace them, but when you combine MRI with any of these nomograms, your results will improve. You can better stratify your patients for active surveillance or for active treatment. This is going to appear in radiology hopefully soon. So you'll be able to see this result. And this really gives us too much insight. And we come up with a plan of developing an NCI nomogram for prostate cancer. And you see the first row. You are the first ones outside NCI seeing this. This is the NCI cancer nomogram with a multiparametric MRI. We have several parameters, and by using MRI and clinical parameters, we're able to stratify the patient for active surveillance or active treatment. Hopefully, you will see this result in AUA 2013. And finally, we use MRI for guiding and monitoring the focal therapy. We are currently doing laser ablation under MRI guidance. We use the commercial visualizing system. And I'm going to show you just one sample case. We have done 14 cases so far. And this is a very, very unique case. There is a lesion anteriorly in the right central gland with a diffusion-guided bilateral decision. It came out with Gleason 4, and the patient picked up the way of getting focal laser ablation. And these are the MR thermometer maps at the oblique sagittal plane. This is damage estimate map, and here you can see that lesion is ablated. And these are the images just 24 hours after the MRI, after the ablation. And there's this dark area which is suggesting necrosis with lots of inflammation around. DC MRI shows that this lesion is necrotic. Of course, it is contaminated with inflammation around. So we imaged him after 6 months, and that lesion looks totally wiped out on T2-weighted MRI, and it's not enhancing anymore on DC MRI. And 1 year after, we imaged him again, and it is shrinking, and it is not enhancing. We did fusion-guided biopsy, 2 parts of this lesion, and just yesterday I learned that it is negative. So we somehow cured this patient by using MR-guided focal laser ablation. So as to conclude, multiparametric MRI, currently the most promising imaging technique to localize and locally stage prostate cancer. It has potential for information of aggressiveness management, and it can be utilized to guide biopsies and focal therapy applications. Well, I think my words, but there's a huge team behind this great research. I would like to thank all of them. Maybe I forgot to put some of the names, but I thank all of them. And this is all their work. I just presented that. And I would like to thank you for your attention.